So today we're going to cover the last bit of information about vessels, in particular focusing on pulse as well as blood pressure. So that then we can do our lab where we're taking pulse and taking blood pressure and looking at some of that data. So we're going to start with pulse. So pulse is just a pressure wave of the blood as it flows through. If we really think about it, right, the blood in particular, the blood in the arteries that is coming straight from the heart, that blood is coming in waves, right? Every time the heart contracts, like we have this, it's a terrible heart, but that's okay. So we have our heart, and then our heart contracts, right? And that's going to force blood. And then it relaxes again, and then it contracts and it forces blood. And so the blood is kind of flowing in this like boom, boom, boom kind of manner each time the heart contracts. So pulse is just that pressure wave of the blood. And we monitor pulse at what we call the pressure points. So basically, what these are points where the vessels are both close to the surface of the skin. They're usually associated with either a bone or some firm tissue in the area where we'll be able to feel the pressure. But these are our pressure points, and so these are where we're going to monitor our pulse from. Okay, when you guys take pulse, we will take pulse at the radial artery site. It is one of our most common sites. So we have a temporal artery site. So it's going to be up here near the eye on the side of the face. Same with the facial artery is going to be here along the jaw. Carotid artery is here in the neck. Okay, that's the one we commonly think of when we see somebody lift their two fingers up towards their neck and take their pulse there. They're taking it at that carotid artery there in the neck. Brachial artery is here in the elbow, and that is actually where you're taking blood pressure from. But so we're not taking pulse from that one usually. Radial artery, again, is our most common spot. That's the one down by the wrist, by the thumb. And we see people commonly taking pulse there. You can take pulse from your femoral artery here in the groin or the inguinal area. Same with popliteal on the back of the knee, posterior tibial down here at the ankle, and dorsalis pedis. Remember, pedis is foot. So down at the top of the foot. So there's a couple of reasons as to why we choose the radial artery as our most common one. First of all, based off of comfort. Comfort for both the patient as well as the doctor. The radial artery is in an easy to reach location here at the wrist. It's not it doesn't make the patient uncomfortable usually that you're touching the wrist. Whereas, for example, if you were taking pulse at the femoral artery, the patient might be uncomfortable that you are trying to take pulse in their groin area. Now, if somebody's injured, you may need to take pulse in some of these other places so you can see if blood flow is moving. But if somebody is, healthy in the doctor's office, you're just trying to assess their pulse, radial artery is the best, most professional place to take it. We commonly see people taking pulse at the neck, which is fine if you are taking your own pulse. But again, from the doctor point of view, taking the patient's pulse, you're having to reach in by their face into their neck. And if you push too hard, you cut off blood supply. And carotid artery is what's taking blood up to the brain. So we don't want to accidentally be pushing too hard and cut off blood supply. So we will be taking it here at the radial artery. And a couple things to keep in mind when you take it. Okay, you use your index and middle finger to take pulse. Okay, we do not use the thumb because our thumb actually has its own pulse, so it can get confusing and difficult to tell which is which. So we use the index and middle fingers to take the pulse, and we want to be gentle. Okay, if we push too hard, we will actually occlude, or in case you see this word on the lab or anything, occlude, which is going to be to close. Here's our vessel that the blood is flowing through. When we push these fingertips down onto it, trying to take, that's a great fist there, trying to take pulse, we're going to push the vessel down just a little bit. And if we push too hard, we can end up completely occluding or shutting off blood flow in the vessel. So we don't want to do that. Okay, so it's a nice, gentle, very light pressure with the index and the middle finger. And then we're going to just be counting pulse. And we will do pulse in your lab, both resting pulse, standing pulse, as well as pulse for while you're exercising. And this will allow you to count heart rate, right? That's all pulse is, okay? Is it is allowing us to count and or calculate heart rate. If we only count for 30 seconds, then we need to do the math, right? We need to multiply it by 2 to get our heart rate, which is going to be our beats per minute. Okay, so let's switch over to blood pressure. So blood pressure is written in a fraction, and so it is our systolic pressure over our diastolic pressure. And so that is going to give you your blood pressure. So systolic pressure, remember, systole was when the ventricle was contracting. So our systolic pressure is going to be our pressure at the peak ventricular contraction. So our diastolic pressure is going to be the pressure in diastole. So this is going to be your pressure that the blood has in the vessels when the ventricles are relaxed. So systolic is actually going to be a higher number because when the ventricle is in systole or contracting, it's pushing more blood. There's going to be more pressure there. And your diastolic is actually going to be a lower number. Your common is 120/70 is what's your considered average blood pressure for an adult. So we have systolic over diastolic pressure. And the further we get from the heart, the more that pressure is going to drop. So as you move further and further from the heart, moving into those arterioles and those capillary beds and back into those veins, the pressure is going to decrease. You can see that in this diagram here. You can see this systolic pressure is pretty high here in the aorta and the arteries. And you can see that it's coming closer to the diastolic pressure, where the two are basically the same as it's moving through the capillaries, through the veins, back into the vena cava. So that blood pressure, those two, being able to get those two separate readings for systolic versus diastolic blood pressure, you're definitely taking pressure from an artery. Like we said before on the last picture, we'll take it from the brachial artery, the artery there in the elbow, using the cuff. Okay, so let's look at the things that can affect our blood pressure. So we'll kind of use this diagram and we'll look at a wide variety of things as we move through here. Okay, so some of the things that can affect blood pressure would be our sympathetic nervous system. Okay, remember our sympathetic nervous system will kick in when we're doing exercise, right? So that's when we're nervous, when we're stressed out, right? But that sympathetic nervous system is going to release hormones, right? And they're going to affect the brain. And so that can impact our blood pressure. And as a general rule, you'll see that it's going to raise it, right? If I'm doing exercise, I'm triggering that sympathetic nervous system. I'm activating, all of these things here are activating that sympathetic nervous system. And that sympathetic nervous system causes some vasoconstriction. So you can see the vessel there getting a little bit more narrow, which is going to help increase blood pressure. It'll also increase, remember, stroke volume, the amount of blood that is pumped out of the heart per beat, and heart rate, which is going to increase our overall cardiac output. Remember, stroke volume times heart rate equals our cardiac output, which is also going to increase our blood pressure. So we have neural control over this, right? In particular, from the sympathetic nervous system, exercise, stress, embarrassment, all things that can trigger that. And the kidneys play an important role in regulating blood pressure as well. So kidneys, if you see the term renal, you need to be thinking kidneys and how they're impacting things. So the kidneys or the renal system here is going to be altering blood volume. So you can see here your kidneys conserve water and salt. So they help regulate your blood volume. So if we regulate blood volume, that can affect pressure. Right? If our blood volume drops a lot, then we actually try to increase pressure. If it gets too high, then we try to lower pressure. So the amount of blood that we're trying to pump through is having an impact on how high the pressure will be as we're pumping it through. So let's look at what we call the renin angiotensin system. So renin, renal, kidneys, angio is vessels, right? So this is going to kind of show us how our kidneys and our vessels are linked together. So renin, so the first step here is that renin, which is a hormone, is released from the kidneys. It's an E there. So renin is released from the kidneys, and it's released from the kidneys when we have a decrease in it's in response to a decrease in blood pressure. So it's released from the kidneys when blood pressure drops. Okay? And what that's going to do is that renin is going to bind to angiotensinogen. So angiotensinogen is in our blood at all times. Okay? Sometimes we have molecules that exist in an inactive state on a regular, constant basis so that when we need them, they're ready to go. And so all I have to do is turn them on. I don't need to create them or anything. I can just quickly activate them and then they will turn on. And so the angiotensinogen is in our body, in our bloodstream at all times, ready to go. And so the renin that's released from the kidneys will bind to this angiotensinogen. And when that renin plus, let's make it obvious, plus that angiotensinogen, that's going to give us angiotensin. So that combination there is going to become angiotensin. And what angiotensin is going to do is angiotensin is going to constrict the blood vessels. And so what I get from forming that angiotensin is a constriction of the blood vessels. And as we see on the diagram over there on the right, when we constrict those blood vessels, we're going to start bringing blood pressure back up. And remember, this was released in response to a decrease in blood pressure. Okay, so the renin's released from the kidneys when the blood pressure drops. It binds to the angiotensinogen, which activates it into angiotensin. So angiotensin is the active form of that angiotensinogen, and that's going to constrict our blood vessels. In addition, the release of that renin, okay, so let's just go over here. So in addition, the release of that renin is going to increase sodium reabsorption by the kidneys. And if we think about what we talked about with diffusion on the last video, that things flow from high to low, if I store more salt, more sodium in the kidneys, then water will actually naturally follow it because now the water level is low because I have a lot of salt. And so that helps us retain the water, which will help increase blood pressure back up. So the renin encourages that sodium reabsorption in the kidneys, and the result is that instead of putting more water into the urine, we reabsorb more water, which is going to increase our blood volume, which will in turn then increase blood pressure. Again, this was released in response to a drop in blood pressure. In addition, we also have what's called, let's talk about all our hormones right now, atrial natriuretic peptide. So atrial natriuretic peptide, this one is released in response to the atria stretching. So what would cause the atrium to stretch out would be having too much blood volume. So what this will do, if there's a large amount of blood volume returning back to the heart, it's stretching the atria out. So we release this atrial natriuretic peptide, which will impact the kidneys as well. In this case, what the ANP will do is the ANP will actually inhibit sodium reabsorption at the kidneys, which will actually stop water reabsorption. So decrease. So there's a decrease there in water reabsorption. Sorry, this keeps trying to turn my microphone off. So there's a decrease in water reabsorption, which results in a overall decrease in blood pressure. So we'll just take this over here. Right, so this is going to decrease our blood pressure. So both of these are acting on the kidneys. So the renin's being released directly from the kidneys and acting on the angiotensinogen to activate it, as well as on the kidneys to increase our sodium reabsorption to try to raise blood pressure. Atrial natriuretic peptide is going to do the opposite. Our heart has registered that there's a lot of blood being returned to the heart. So we stop absorbing sodium at the kidneys, which will decrease the amount of water we retain. So more water is headed into the urine. So that would decrease blood volume, which would in turn decrease blood pressure. Okay, so I'm going to clear these things off. So if you don't quite have everything yet, pause it so you can make sure you get it. Okay, so on this diagram here, you can see where the renin was coming into play here, causing this vasoconstriction, which increases peripheral resistance. So peripheral resistance is exactly what it sounds like. It's resistance in the arteries to blood flow. So basically, how wide is the diameter of the arteries? Is there something clogging the artery up? Okay, so it's the resistance in the arteries to blood flow. So anything that causes vasoconstriction is going to increase peripheral resistance because I've narrowed or constricted the artery now. So certain chemicals, like you see listed there, like the renin will and the nicotine will, so from cigarette smoke. Okay, also things that increase blood viscosity, right? Viscosity is our thickness of the blood. So things that increase blood viscosity are going to increase peripheral resistance. They're going to slow that down, which all in turn are going to increase blood pressure. Okay, so when we impact peripheral resistance, like for instance with heart disease or something like that, that's where we start to see that increase in blood pressure as well. Body temperature can have an impact on pressure, right? When we get too hot, right, in response to heat, we do a vasodilation response, right? So if I'm doing a vasodilation response, I'm going to decrease resistance, which will in turn which will in turn decrease my pressure, right? When it's cold, we see a vasoconstriction response. And as we just mentioned, vasoconstriction is going to increase peripheral resistance, which will increase our pressure. So in addition to these, there's also plenty of other factors that come into play that have an impact on blood pressure, some of which we can control, some of which we can't. Things like our age, right? Just as a general rule, as we age, things start to kind of break down. They start to change. Our race, it can impact blood pressure, because race has certain DNA traits that are in common that can impact this. Our family history, again, coming back to genetics, right? So our family history of heart disease or high blood pressure, that could have gotten passed down to us. Weight is going to have an increase on blood pressure. So the more we weigh, we have an increased need for nutrients to feed those tissues, to feed all those cells, and to feed all those tissues. So if I have an increased need for nutrients, then that makes me have an increased blood volume. And an increase in blood volume is going to cause an increase in pressure. So that high weight, obesity, right? We've increased the nutrient requirement, which means we had to increase our blood volume, which means we have to increase our blood pressure. Okay, so that would tie right in with diet, okay, in particular for weight management, as well as exactly what we're putting in our body. Is it actually fueling our body to help it, get stronger and be healthy and grow better? Same with exercise. We've already kind of pointed out on our diagram that exercise will, in the moment, exercise will increase blood pressure. However, what exercise does, right, is exercise works our heart muscle. So basically, exercise is training our heart muscle, just like the cardiac exercises, just like when we weightlift, right? And if we're weightlifting, trying to get big muscles, right? We're trying to train those muscles. When you're doing a cardio workout, you're training your heart muscle basically to make your heart more efficient so that every time it contracts, it's pumping the most amount of blood that it can. It's being very efficient. So while in the moment that exercise will raise blood pressure, overall exercise, regular cardiac exercise decreases our blood pressure, right? It decreases our resting heart rate because our heart is more efficient. Our heart is more efficient, so it doesn't have to work as hard to pump blood around. So when we're less active, our heart is less efficient, and so our resting heart rate needs to be is usually a little bit faster, as well as our blood pressure is usually a little bit higher, trying to encourage that blood flow. Okay, we've already mentioned tobacco use with cigarettes. We saw the nicotine on the diagram. Okay, those also damage in addition to causing that vasoconstriction, they usually cause damage to the walls of the artery. And damage to the walls of the artery is going to increase our peripheral resistance. Okay, for certain people, the amount of sodium has an impact. Right? If I'm eating ridiculous amounts of salt, tons and tons and tons of salt, that can cause me to retain water. And as we already saw, retaining water can increase our blood pressure. And then also stress can increase our blood pressure because as we know, stress elicits that sympathetic nervous system response. So it increases that release of that adrenaline, that norepinephrine. Okay, so we will be taking blood pressure, taking pulse, and then kind of analyzing that data and talking about, what would happen, what's the difference between an athlete and that kind of thing.